Assalamu alaikum dear students. I am your course instructor Aiza Yousaf for the course of Gerontology and Geriatrics Physical Therapy. Today we are going to learn about delirium. After this lecture, you are able to learn how cognitive and psychological changes associated with aging. Then, among these changes, how delirium will reduce functional performance in later life, and how it can be assessed, and what are its clinical manifestation, and what are different management strategies to overcome delirium. Now, let's start about what is delirium. It is a clinical state that is characterized by acute fluctuating change in mental status with inattentiveness and altered level of consciousness. It is also known as acute confusional state. Delirium is used to describe confusion with hyperactivity. That's why we called it acute confusional state. Severe confusion will be described as delirium, while mild disorientation will be described as acute confusional state. There are three types of delirium. One is hyperactive, the second one is hypoactive, and the third one is mixed. In hyperactive delirium, which prevalence is 25%, psychomotor activity is increased and agitation is prominent. In and it is misdiagnosed with anxiety. Hypoactive delirium also present in 25% of patients. In hypoactive delirium, psychomotor activity is decreased, misdiagnosed as a depression or undetected. Mixed delirium. In 35%, there is psychomotor activity with the hypoactive and hyperactive feature, while in 15% cases, psychomotor activity is normal. Now, here is the question is, what is psychomotor activity? Psychomotor activity is defined as motor physical activity that is secondary to or dependent on a psychic component. Just like psychomotor agitation is a symptom related to a wide range of mood disorders. People with this condition engage in movement that serve no purpose. For example, pacing around the room, tapping your toes, or rapid talking, or remove bed linens, etc., etc. So, this psychomotor activity in hyperactive type, this may be due to some alcohol withdrawal or some drug abuse or drug withdrawal. It is the classical example of hyperactive type, and it is also known as delirium tremens. While hypoactive type, the benzodiazepines intoxication is an example of this type. It is the drug overuse. In spite of two distinct types, most patients fall in between these two types and fluctuate from one type to another. That's why there is a larger prevalence in mixed delirium. Now, its epidemiology and etiology. What are its causes and risk factors? It is very common in elderly population, and it may affect general medical patients whose age is equal to or more than 70 years old and also admitted to the hospital. 10 to 20% patient are confused at admission, while 10 to 20% become confused during hospitalization. The incidence of post-operative delirium among patients whose age is equal to 17 years or more than 17 years will be 15 to 20% after elective procedures and 35 to 65% after emergency procedure. As delirium is the confused state of person, in which patient may be disoriented or agitated or hyperactive or maybe hypoactive. During hyperactive, the person may be response or inadequate movement, which is not necessary. While during hypoactive, there is a more worse condition, as the patient nutritional deficiencies may be reduced, or his or her movement or activity will be reduced. That way, it will be more dangerous. So it is a acute. There is an acute onset of delirium. It can be changes from day to day or from hours to hours. That in the morning patient may be normal, while in evening patient may represent confused or some disoriented state of his or her mind. That's why we call it acute confused state, and that is more common in elderly patients, especially the patient with comorbidity, and that's why the elderly patient may have more than one morbid condition, and that morbid condition may induce, may influence patient to take medicine. So when patient is taking medicine for more than one condition, then we called it polypharmacy. And with the increased drug use, it can also cause delirium. So it may be due to hospital admission, fright of hospital admission, or due to hospitalization due to poor light, etc., etc. These all come under the risk factors or etiology of delirium. There are some advanced risk factors such as old age, underlying dementia. Maybe patient have dementia, so when patient is suffering from loss of memory, then patient may be may become agitated, or there may be functional impairment as well when patient is not oriented with the reference to his time, place, and time, place, and person. Then there may be some functional impairment. Drug use I have cleared previously. There will be some electrolyte and physiological abnormalities which may cause delirium, that is the confusional state of mind. Some underlying infection. When there is a reduced sensory input, we also become agitated. Increased intracranial pressures or urinary retention. As with urinary retention, there will be ammonia or nitrate compounds, which may affect your brain function, or as a result there may be confusional states arises. Myocardial problems. Due to myocardial problem, there will be decreased supply of oxygen or blood. It may also cause delirium. Now, what is the pathophysiology of delirium? The pathophysiology of delirium is unknown. Maybe there is increased serum anticholinergics activity. Anticholinergics are the transmitters or chemicals that that work against the acetylcholine. So when anticholinergics will become increased, the work of acetylcholine will be decreased as the amount of acetylcholine will be reduced. There may be some endogenous factors. That endogenous factors means having an internal cause or a region. Some drug therapies, over-the-counter medications, or increased dose of drugs, and then it may be vulnerable to decreased cholinergic transmission. It's obvious that when serum anticholinergic activity will be increased, then there will be decreased cholinergic transmission, which is acetylcholine. Then levels of phenylalanine and tryptophan may be abnormal. Phenylalanine and tryptophan, which are amino acids, essential amino acids in our body, which will be responsible for making protein. When their level will be abnormal, patient may suffer from delirium. So any type of imbalance in amino acids, serum electrolytes, transmitters, or some metabolites, it may cause delirium. Some are there are sign and symptoms. Clinical features include impaired attention, acute cognitive dysfunction, which may develop suddenly or over a short time. It will not progresses along with the age or progresses with the passage of time, but it develops suddenly or short notice of time. It may changes from hours to days, or it may prolong from hours to days, or there is acute fluctuation in mental status. There is varying level of inattention, altered level of consciousness, and psychomotor activity may be variably abnormal due to level of arousals or different sorts. Some other signs and symptoms include hallucinations. Patient may feel someone is there, or with the reference of seeing. So other things which is not present, delusions, false beliefs. There may be tremors, abnormalities in sleep-wake cycle. It may persist for many weeks or months, from days to many weeks or months. It may be infrequent and never clear. It is infrequent and never clearly resolved. It modulates into chronic cognitive dysfunction, which is dementia, if it persists for longer period of time without untreated its cause. Now the diagnosis. How we can make a delirium diagnosed? It is very difficult to diagnose delirium, as it is and they as in delirium there is different and there is change in mental status. So to diagnose that change, we should have to know about the baseline mental status, that where the patient is about in their mental status. That's why it is very difficult to diagnose delirium. For the diagnosis of delirium, the underlying cause should be identified properly. So we can treat the cause symptomatically. When cause will be removed, delirium will be resolved. Failure to diagnosis or misdiagnosis will be occurred to delirium in 80% of the cases, and there may be input in the diagnosis of delirium. The input will be given from physicians, nurses, and persons who know the patient well, such as family members. So when we know the patient well about his personality, his mental status, then we can identify the changes in which occur in their mental status. Now, what is the diagnostic criteria for identifying delirium? Disturbance of consciousness with reduced ability to focus, sustain, or shift attention, which is inattentiveness or carelessness, will result in delirium. Change in cognition or development of perceptual disturbance that is not better accounted for by pre-existing, establishing, or evolving dementia. The disturbance develop over a period of short time. So there should be change in consciousness or mental status or attention, but that change will not be pre-existing or may not be due to some other medical condition. It is purely acute. It purely has an acute onset, means it develop within a shorter period of time. For delirium due to there is some reasons from which delirium may be occur, and it may we will discuss it further one by one. For delirium due to journal medication, we can get evidence from the history, physical examination, laboratory tests that the disturbance is due to the direct physiological consequences of journal medication. As we have discussed earlier, that the certain medications which we use for over a long period of time, drug abuse or some other alcohol, etc., may cause delirium if they use for longer period of time. For substance intoxication delirium, just like alcohol or some other antipsychotics or some sleep induced medications all may cause delirium. So, delirium may be occur when substance withdrawal will be done. That's why we called it for substance withdrawal delirium. For delirium due to multiple etiologies, which have more than one comorbidities, or maybe patient taking patient is on polypharmacy, or plus patient is hospitalized, plus a patient has some or prolonged use of certain medications, patient is on psychotic drugs from prolonged period. That's why it has more than one etiology for the cause of delirium. So we have to deal it all around. We have to deal these etiologies simultaneously for the betterment of the patient. Now, history. What we ask the patient during history while taking a patient, while taking it from the patient who is suffering from delirium. We ask the patient to determine the frequency and duration of mental status changes and other clinical features. Our drug review focuses on changes in the drug regime that may have precipitated the delirium. For example, there may be some change in the medicines, there may be a removal of some medicine, or there may be dose changes. Sometimes you people have noticed in your family when your elderly member of the family have gone through from some consultancy, and if they have some change in medications or their dosages, at the day 1 or 2, patient may suffer from agitation, there may be change of some psychoactive drugs like sedatives, hypnotics, antidepressants, anticholinergic drugs, and opioids may also cause delirium. Use of over-the-counter drugs and alcohol should also be reviewed, as it can also be cause delirium. Over-the-counter drugs may result in increased or excessive presentation of drugs. That's why we should consider over-the-counter medications. Now, physical examination. It can be challenging in patients with delirium, as the patient is agitated or restless, become restless due to change in its mental states or confused. That's why it may be challenging for the medical health professionals. For example, vital signs like pulse, blood pressure, respiratory rate, temperature, and oxygen saturation. It will provide the major clues for diagnosis of the delirium, as if the neurotransmitter acetylcholine, if there is decreased acetylcholine, then its activity will be reduced at parasympathetics, where parasympathetic synapses will be affected, and resulting in change in blood pressure, vessel dilation, respiratory rate. That's why vital sign will give us a major clue in it. As well as from vital sign, we also examine the cardiac system, pulmonary system, or neurologic and mental status examination. Now, confusion assessment method, which is also known as CAM. The CAM is a validated method for diagnosing delirium. After history taking and physical examination, we use specific questionnaire or specific diagnostic criteria, specific diagnostic tools or questionnaire, which will help us to find out whether the condition is present or no. As in the previous assignments, one of your group member has given the topic about mini mental state, MMS, state examination, or mini mental state, MMS or MMSE, with the help of which we can assess a patient mental status. It is no, we are not restricted to use only one questionnaire or one tool. We have lots of tools which identify single problem. So we can use another method, which is confusion assessment method, and it is the validated and diagnostic criteria for diagnosing delirium. A positive or negative result depends on four criteria. It has four parts. One is the acute onset and fluctuating course. The second one is the inattention, and the third one is the disorganizing thinking and altered level of consciousness. So when the patient is represented with the 4 or 3, then the CAM is considered to be positive for the presence of delirium if both features, number 1 and 2, which is the acute onset and fluctuating course, and number second is inattention or carelessness, are present with at least one of the features 3 or 4, either disorganized thinking or either altered level of consciousness. Then minimum 3, 1 and 2 will be compulsory, while 3 and 4 may be third or maybe fourth may be present. Then we called it that delirium is, patient is suffering from delirium, or delirium is present in this patient. Now there are some other laboratory tests guided by history or drug review and physical examination. We ask the patient or we perform some laboratory tests to get a more clear picture. We ask the patient to do CBC, serum electrolytes, urine analysis and cultures, CT scan, cerebrospinal fluid analysis, and electroencephalography, electrocardiogram, and X-ray. Now, we have some differential diagnoses that depression is a psychiatric disorder characterized by pervasive low mood, loss of interest in usual activities, and diminished ability to experience pleasure. While dementia is the progressive deterioration in intellectual function and other cognitive skills. While the delirium is the acute onset of change in the mental state, attentiveness, and these three conditions are different from one from one another, as dementia is the chronic or progressive changes, while delirium is the acute onset. In depression, there is always negative vibes in the patient, while delirium is delirium is referred to the changing mental status, and it may persist for shorter period of time, while dementia and depression may persist longer. Now, what are the complications in delirium? There may be bladder and bowel incontinence or retention, iatrogenic problems, the problem which may be due to the problems may occur in the patient health due to false treatment or misdiagnosis, or misdiagnosed treatment will be given. But as due to delirium, a patient may be bedridden patient are prone to atelectasis, deconditioning, pressure sores, and acute malnutrition. We get as the delirium may occur in terminally ill patients, as we ICU patients, or severe older aged patient with multiple comorbidities. So if patient is suffering from delirium, it may be bedridden and may suffer from may suffer from atelectasis, deconditioning, pressure sores, and acute malnutrition. Now, what will be the prognosis and treatment? Hospitalized patients have 10 times more risk of medical complication when suffering from delirium. So, if patient has longer hospitalization, it may cost higher hospital costs and increased need for post-acute placement at discharge. There should be removal of the treatment should include removal of contributing factors, or the removal of definite causes which cause or which predispose the delirium. There avoiding unforeseen complications, support of the family and patient will be helpful, and educate patient. How we can educate patient and all? How we can educate patient? We ask the patient encourage them to rest and sleep, keep their room quiet and calm, make sure they are comfortable, encourage them to get up and sit in a chair during the day. I mean, we should engage patient in his ADLs and encourage his sleep pattern and normal day-to-day activities, as well as engage patient in flexibility exercises or range of motion exercises, etc., etc. So, as a whole, the summary of the today's lecture is that acute confusional state or delirium is a state of reduced mental clarity, coherence, comprehension, and thinking compounded by inattention, attention deficit, and disorientation. There are two types: hyperactive and hypoactive. And the third one is the mixture of hyperactive type and psychomotor activities. We have so for the assessment of these patients, we have a history, we have physical examination, we have laboratory test, and we have some specific tools like CAM, which is the international diagnostic criteria for the delirium. And for the CAM, there are four points. First and second should be present for the confirmation of delirium, while third and either third point or fourth point will be present uh, for definite diagnosis. Then there will be no definite treatment for delirium. We just tackle the patient according to its signs and symptoms and its causes, which causes delirium. So we have to cover all domains for such patients, like if patient is suffering, where patient has polypharmacy, and patient delirium is due to increased use of drug interaction, and so we have to manage, or doctor, his physician have to manage such control, such cause which causes delirium. So while physician is doing his job, then we have to do our job, which is to maintain patient active, guide patient, maintain conducive environment for the patient. Thank you. That's all from today's lecture. If you have any query or the point you have not understood properly, note it down. We will discuss it in our interactive session. Thank you. Take care. Allah Hafiz.